हेलो। सो होपफुली आप सब ठीक हैं। थर्ड ईयर आज का हमारा लेक्चर है। कंटिन्यू करेंगे हम लोग एडवर्स रिएक्शंस ऑफ लोकल एनेस्थीसिया, डेंटल लोकल एनेस्थीसिया। आप लास्ट टाइम भी हमने पढ़ा था ये, इसके अंदर बच्चों की स्ट्रेंथ थोड़ी सी कम थी, सो आई एम गोइंग टू रिपीट अ फ्यू स्लाइड्स। एडवर्स रिएक्शंस ऑफ लोकल एनेस्थीसिया कैन बी कैटेगराइज्ड इनटू सिस्टेमिक एंड लोकल। लोकल का मतलब है कि लोकल एनेस्थीसिया इन्फिल्ट्रेशन या ब्लॉक ओरल कैविटी में जब देते हैं पेशेंट को, तो पेशेंट को जो भी कॉम्प्लिकेशन होती है, लाइक ब्लीडिंग, लाइक इन्फेक्शन, लाइक अ ब्रोकन नीडल और एनीथिंग, तो दोज आर कॉल्ड लोकल कॉम्प्लिकेशंस. Systemic complications are when the local anesthesia causes a problem in any system of the patient, like the CNS. LA toxicity excessive dose अगर हो जाए LA की, that can cause CNS that can show the patient can show CNS symptoms with toxicity. So आज हम वही करेंगे. सबसे पहले है सिस्टेमिक एडवर्स रिएक्शंस. इसके अंदर देर आर सम साइकोजेनिक रिएक्शंस. साइकोजेनिक रिएक्शंस कैन बी ऑफ एनी टाइप. द मोस्ट कॉमन टाइप ऑफ साइकोजेनिक रिएक्शन कैन बी अ वेजोवेगल सिंकपी. Some people have absence seizures. Some people have hyperventilation syndrome. So all of these are psychogenic reactions in which the patient takes too much stress and shows these reactions. उनको मैनेज किस तरीके से करना है हम आगे पढ़ेंगे, बट जनरली वी मैनेज देम विद एंग्जाइटी रिडक्शन प्रोटोकॉल. नेक्स्ट इज एलर्जी. देर आर मल्टीपल कंटेंट्स ऑफ अ लोकल एनेस्थीसिया कार्ट्रिज. उसके अंदर जैसे वेजो कंस्ट्रिक्टर है, एल एजेंट है, देर इज़ रिड्यूसिंग एजेंट होता है सोडियम मेटाबाइसल्फाइड, प्रिजर्वेटिव होता है मिथाइल पैराबेन. तो मोस्ट कॉमनली जो एलर्जी होती है वो मिथाइल पैराबेन जो प्रिजर्वेटिव है, जो फंजिसाइड है, उससे होती है. एंड दैट हैज़ बीन रिमूव्ड बाय द ADA इन द लेटेस्ट in the newest local anesthesia systems. Preservative has been removed because it has shown to cause allergy. दो किस्म के लोकल एनेस्थेटिक्स जो होते हैं, एस्टर्स एंड एमाइड्स, आपको पता है. सो एमाइड्स से एलर्जी इज़ वेरी रेयर. एस्टर्स से एलर्जी इज़ पॉसिबल बिकॉज एस्टर्स दे मेटाबोलाइज इन द प्लाज्मा. Okay, toxicity is when there is excessive dosage to the there is excessive toxicity is when there is excessive local anesthesia in the system of the patient. So अगर dose enhance कर दी जाए, if आगे हमने पढ़ा था डोज कैलकुलेशंस के अंदर, हाउ मेनी कार्ट्रिज ऑफ लोकल एनेस्थीसिया कैन बी गिवन. सॉरी, बीच में थोड़ा सा मैं डिस्टर्ब हो गया जी. हाउ मेनी कार्ट्रिज ऑफ लोकल एनेस्थीसिया कैन बी गिवन. अगर हम उसको उससे ज़्यादा चले जाते हैं तो that can lead to toxicity. or if we don't do aspiration, और क्या एक when we administer local anesthesia and locally उस जगह पे anesthesia देने के बजाय if we administer that local anesthesia into a blood vessel, that can lead to increased systemic dose of the local anesthetic. That can also lead to toxicity. मेट हीमोग्लोबिनीमिया आगे पढ़ेंगे क्या होता है. सो साइकोजेनिक रिएक्शन जैसे मैंने आपको बताया है, एंग्जाइटी इंड्यूस्ड रिएक्शंस होते हैं. सिंकपी इज़ द मोस्ट कॉमन. अदर इंक्लूड हाइपरवेंटिलेशन, नोजिया, वॉमिटिंग, चेंज इन हार्ट रेट और ब्लड प्रेशर. नॉर्मली आपको पेशेंट जो है ना हमारे सेटअप में बताएंगे, डॉक्टर साहब मेरा दिल घबरा रहा है, दे विल स्टॉप टॉकिंग. सो इफ़ यू सी अ पेशेंट स्टॉप टॉकिंग आफ्टर एडमिनिस्ट्रिंग लोकल एनेस्थीसिया, देन you need to stop the procedure and counsel the patient maintain his oxygenation, and if needed, maintain an IV line if the patient has other medical problems. Next is allergy. Allergy मैंने आपको बताया है, it is some uh, uh, this line is very important. Actually, I had a patient once who had history of multiple allergic reactions whenever she had a um dental appointment, and she was referred to us from a very well known clinic in Lahore. And like I said, it is actually very rare to have local anesthesia allergic reactions. The contents of local anesthesia are very non-allergic, and especially we don't add the preservative anymore like methyl paraben. So local anesthesia allergies are very rare actually. So she was referred to us, and we analyzed her history and everything, and we thought that the she doesn't have any allergies, but the problem is psychogenic. So we did allergy testing on her. Allergy testing कैसे की जाती है? We in a controlled environment like an ICU, we with airway support, with systemic support, we administered a test dose of local anesthetic into her forearm, and we noticed any reactions and noticed any changes in the skin color, any itching, any dyspnea, any allergic symptom. But she was fine, and the test was repeated after every 30 minutes, and she remained fine. So this line is very important, that allergic reactions to local anesthesia are somewhat common, but these reactions seem to be of psychogenic origin. So allergy is rare. If you find a symptom of allergy, uh, need to you need to revise your differentials, because maybe it is psychogenic, or maybe it is toxicity. You're not aspirating enough and introducing this local anesthetic into the system. Okay, an allergy to one ester rules out using another ester, goes without saying. Amide allergy is very rare, but an allergy to one amide does not rule out using another amide. So epinephrine is basically given to treat allergies, so it hasn't showed any allergic potential so far. Okay, like I said, methyl parabens have potential for causing allergy. Okay, they have been removed from the dental cartridges now. So if there is excessive systemic absorption of an excessive amount of drug, that can lead to a toxic reaction. Local anesthetics block conduction in many tissues. In addition to the peripheral nerve, toxicity could result if sufficient amounts of the anesthetic reach these other tissues such as the heart or brain. So let's suppose you have a patient and he's saying that you're trying to when you're trying to extract his or her molar, let's say mandibular first molar, and the patient keeps complaining, I have pain, and you keep depositing anesthesia, there is going to be a limit to which you can deposit local anesthesia, and after a while that will actually lead to toxicity. So make sure to avoid toxicity, you need to know which anesthetic agent is being used, what is the maximum limit of that anesthetic, and also you need to use aspiration technique at all times. High blood levels of the drug may be secondary or to repeated injections, or could be a result of single intravascular admission. So, okay, like I said, make sure you do aspiration correctly. Okay. Toxicity also depends upon factors such as the site of administration, the speed of the injection, and the presence of a vasoconstrictor. So, if you have a vasoconstrictor, chances are toxicity nahi hogi. But if there is a vasoconstrictor, if there is no vasoconstrictor, which in the anesthesia, which is called plain local anesthesia, then there are chances that first of all you need to administer more local anesthesia because it is being absorbed more in the system, and also secondly you need to uh, make sure that you do aspiration before administering the local anesthesia. Okay, this is a table that we also revised last time I was in the theater with you guys, and this you can see in this is important here. The number 13, lidocaine 2% with epinephrine has a maximum dose of 7 mg per kg. In a 70 kg person, you can only give 13 cartridge of that. Okay, dose calculation. We did the dose calculation the last time. I'm going to skip this. Methemoglobinemia. Okay, so this is a condition most notably with prilocaine, but can also occur with articaine or the topical anesthetic benzocaine. What happens is it induces an excess induced by an excess of metabolites of these drugs and presents as a cyanotic appearance that does not respond to the administration of 100% oxygen. What happens is हीमोग्लोबिन के साथ अटैच हो जाता है जाकर एक compound which is a orthotoluidine, which reduces the hemoglobin to methemoglobin, and that has less oxygen carrying capacity. Okay, so होगा क्या कि हम पेशेंट को प्राइलोकेन इंजेक्ट करेंगे, वो प्राइलोकेन मेटाबोलाइट जो होगा प्राइलोकेन का मेटाबोलाइट होगा ऑर्थोटोलिडीन, which will change the structure of hemoglobin to methemoglobin. Cyanosis become apparent when methemoglobin levels are low, but additional symptoms of nausea, sedation, seizures, and even coma are very high. Prilocaine, articaine, and benzocaine are best avoided in patients with hereditary methemoglobinemia, obviously. So, next, to summarize, you can see psychogenic reactions include syncope, hyperventilation, nausea and vomiting, tachycardia, hypertension, bradycardia, hypotension, and appearance of an allergic reaction. To summarize allergy, you can see esters. Possible allergens are esters. Amide allergy is very rare. Metabisulfite and methylparabens, which have now been removed, are also potential allergens. Okay, if there is toxicity, you can find the patient symptoms to be like mild, moderate, and severe. Mild symptoms will include patient will feel sleepy, lightheadedness, slurred speech, muscle twitching, disorientation. The patient can also say my perioral area is numb, and moderate symptoms include tremors, respiratory depression, and if the symptoms are very severe, it can lead to firstly there will be a CNS excitation, which will be followed by a CNS depression, and the patient can go into coma as well. So make sure you aspirate, make sure you're not overstepping the local anesthesia dosage. Methemoglobinemia, like I said, is a condition consistent with prilocaine, and what happens is orthotoluidine, metabolic product of prilocaine, can bind to the hemoglobin present in our blood and convert it into methemoglobin, which has less oxygen carrying capacity. Now coming to the local adverse reactions, firstly there is trismus, which is limited mouth opening due to any reason. Then can be a hematoma. Hematoma, like the name suggests, is a swelling of containing blood prolonged anesthesia or paresthesia, okay, pain on injection, needle breakage, that is a very serious local complication, soft tissue injury, facial nerve paralysis, and at the end superfluous anesthesia. Okay, there's one more infection also. So trismus, trismus can be trismus after extraction, trismus after local anesthesia can occur due to multiple reasons. The most common being multiple needle pricks into the medial pterygoid muscle. You know, when we're depositing inferior alveolar nerve block in the pterygomandibular space, the contents of the pterygomandibular space contain buccinator muscle as well as the medial pterygoid muscle. Now, if you do multiple injections there, the muscle can get injured and it can actually go into spasm, and that can lead to trismus. Also, if you do multiple injections and you damage the periosteum, underlying periosteum, that periosteum is highly sensitive and it has a very profuse blood supply. That can lead to small hematomas subperiosteally, which can also lead to trismus. So make sure you do not contact the bone multiple times. Make sure your technique is right to avoid trismus. Okay. It can arise anywhere from 1 to 6 days following an injection. Duration of symptoms and severity is very variable. Improvement should be noted within 2 to 3 days. If there is no improvement within this time, the dentist should consider other possible causes, for example, infection. Yes, if there is an infection hoga, that can also affect the medial pterygoid, the masticator space, which will in turn cause muscle spasms, and that can lead to trismus. Treating trismus, how to prevent it? First of all, follow the basic atraumatic injection technique. But if there is trismus, ask the patient to apply hot moist towels to the site approximately 20 minutes each hour. What will that do? It will cause vasodilation, it will relax the muscles, and the mouth will be opened slowly. Prescribe any analgesics. Advise the patient to gradually open and close the mouth as a means of physiotherapy. Next, hematoma. Hematoma can the prone patients for hematoma basically are patients on blood thinners, patients having hereditary conditions in which their blood is very thin. So inadvertent nicking मतलब prick हो गई blood vessel during the injection or withdrawing the needle can lead to a hematoma. This hematoma is common in maxilla, not in mandible. Maxilla में specifically when we are giving a posterior superior alveolar nerve block, वहाँ पे होता है pterygoid venous plexus. That pterygoid venous plexus can actually get nicked and can lead to a local hematoma, which is very painful and takes a good 7 to 10 days to resolve. The patient will notice swelling and discoloration lasting from anywhere between 7 to 14 days. Follow basic principles of how to prevent an hematoma. Follow basic principles. Make it as atraumatic as possible. If the patient is on blood thinners, make sure you follow the technique correctly and you don't have to prick multiple times. Use a short needle for the posterior superior alveolar nerve block. How to manage? If the hematoma is visible immediately following the injection, apply direct pressure if possible. So you know that let's suppose you're extracting a mandibular central incisor and you do infiltration anesthesia in the labial vestibule, and all of a sudden you notice a small hematoma in the vestibule increasing in size slowly, a reddish swelling which is increasing in size slowly. Right away you should apply direct pressure over it so that the bleeding does not advance. Once bleeding has stopped, discharge patient with instruction to ask the patient to apply ice to the site for the first 6 hours. फर्स्ट 6 आवर्स में जितनी आइस पेशेंट अप्लाई कर लेगा ना उतना फ़ायदा होगा पेशेंट को. देयर इज़ नो नीड टू अप्लाई हीट बिकॉज हीट विल कॉज vasodilation and that will actually increase bleeding. Ask the patient to use any analgesics. You can also prescribe antibiotics because blood is a very good medium for the bacteria to come and cause an infection. Counsel the patient that there will be discoloration. That discoloration can also travel extra orally and it will look bad. So just counsel the patient. Prolonged anesthesia or paresthesia. Sometimes the tongue is supplied by the lingual nerve and the lip is supplied by the mental nerve. There can be prolonged anesthesia. These reactions are most often found after block techniques and much less after infiltrations. What happens is needle trauma or injection to directly into the nerve can actually injure the nerve and lead to a prolonged anesthesia or paresthesia. Vast majority of paresthesias are transient, resolving within 2 months, but they can become permanent. Change in the character of the symptoms is encouraging in that it may indicate healing of the nerve and resolution of the symptoms with time. The patient may regain normal sensation. So just counsel the patient that sometimes a local anesthesia injection, it is a blind technique. A local anesthesia injection can actually injure the nerve and that can lead to a anesthesia or paresthesia. Unfortunately, there is no guaranteed method of treating prolonged anesthesia or paresthesia. Excuse me. How to prevent it? If the patient feels electric shock like pain when you're injecting, move the needle away from that side. Do not store cartridge of local anesthesia in disinfecting solutions. Minimize the use of articaine and prilocaine for block technique. Okay, articaine and prilocaine can actually damage the nerves. Advise the patient that the paresthesia or anesthesia is usually temporary. Note the signs and symptoms and follow up within 1 month. If symptoms persist for more than 2 months, refer the patient to an oral and maxillary physician who has experience in this field. Excuse me. If the needle goes into a sensitive structure such as a muscle or tendon, or if the local anesthesia is administered too quickly, that can lead to pain or burning sensation. Local anesthetic solutions at extremes of temperature may also cause discomfort. Solutions that are more acidic, that is, those containing a vasoconstrictor, may cause a short-lasting burning sensation. So make sure you deposit the anesthesia nice and slowly. The recommended time is 1 ml of local anesthesia administered per minute. So if we have a 1.8 ml or a 2.2 ml cartridge, the average time of finishing your cartridge should be around 2 minutes. So you have to go very slowly. Cartridges stored in a disinfectant solution such as alcohol may have residual amounts of solution on the end of the cartridge, which can then be inadvertently during injection. So normally cartridges come in packed in containers. There used to be an old practice of disinfecting those cartridges as well. That has been stopped now, but should not be used anymore also. 1 minute per 1 ml. Store cartridge at room temperature. Okay, sometimes the cartridge in winters, the cartridge is the contents of the cartridge are very cold because of the room temperature, because the room temperature is also very cold. So what you need to do is remove the cartridge from the pack and place the cartridge in the palm of your hand and close your hand. Make sure you warm the cartridge with your hand first before administering the local anesthesia. If you cannot do this, you need to have a water bath in your clinic and warm those cartridges. Otherwise, depositing cold cartridges can actually lead to pain and burning sensation. Pain and burning sensation is self-limiting. There is no need to treat it. Just counsel the patient that it's going to get better. Needle breakage. It is actually very rare, but sudden unexpected movement of the patient is the primary cause. Uh, of Goes without saying that smaller diameter needles are weaker and they are more likely to break than the larger diameter. That is why we administer larger needles, more thicker needles for block anesthesia, because we need to go deeper. Okay, this point is very important. Needle breakage usually occurs at the hub. Hub is where the needle is exiting from the syringe. That point is the weakest point of a needle. So complete needle should never be inserted into the tissues completely. Only 2/3, maximum 2/3 of the needle can go inside. Bending a needle may also may be considered for injection techniques. It is important to do so only once. Okay, so if you need to bend the needle, for example, when we are giving intrapulpal anesthesia or when we are giving a echinosi nerve block, we need to bend the needle. A slight bend of 15 degree is required. So bend it just once. If you bend it 2 times, 3 times, 4 times, that can actually weaken the needle at the bending turn, and that will lead to a needle breakage as well. Okay, so how to prevent? Do not insert the needle too deep. Use long needles if a depth of more than 18 mm is required. Use larger diameter needles for deeper blocks. Also, do not apply excessive force on the needle once it is inserted in tissue. If redirecting a needle is required, withdraw it almost completely before doing so. Do not bend a needle more than once. You see, the needle has broken, and if you notice here, do you see this white line, oblique white line just above the red arrow? That is the needle which has broken. How do you manage this? Let's suppose you're giving a local anesthesia nerve block and the needle has broken. Right away, remove the syringe. Ask the patient to remain calm. Ask the patient to remain still. Keep your mouth open by keep the mouth open, patient's mouth open by removing your hand. If a portion of the needle is visible, remove it with a hemostat or similar instrument. Okay, so hemostat is an artery clip. Just remove the needle slowly. If the patient moves, the needle will go into deeper tissues. If it is not visible, inform the patient. Record the event in the patient's chart. Okay, this is very important. To inform the patient. Inform the patient that the needle has broken and it has gone into deeper tissue, but not to worry, we are going to remove it. Refer the patient to an oral and maxillofacial surgeon, who will basically first do a radiograph, try to localize, and then raise a full flap to remove the needle. Soft tissue injuries. आप में से किसी को कभी लोकल एनेस्थीसिया ब्लॉक लगा हो तो वो फीलिंग पता होगी. जब लिप नम होता है, चीक नम होती है, तो गलती से टंग या लिप बाइट हो जाता है. दैट कैन लीड टू अ सॉफ्ट टिश्यू इंजरी. समटाइम्स ऑल्सो नीडल जो है वो भी लिप पे कभी कभी प्रिक हो जाता है पेशेंट के, इफ़ यू आर नॉट कॉन्सेंट्रेटेड इनफ. सो मेक श्योर पेशेंट्स who have seizures or Alzheimer's or any neurological conditions, they can make sure they don't move very abruptly when you're administering local anesthesia. Do you see this? This is a soft tissue injury in the palate. Okay, for mentally challenged patients or pediatric patients, warn the patient or guardian to watch the patient carefully for the duration of soft tissue anesthesia, because if a patient is mentally challenged and उनको local anesthesia आपने लगाया हुआ हो तो बहुत different feeling होगी lip की, and they may try to bite their lip. So ask the parent to make sure कि वो bite ना करें. If injury हो गई है, use analgesics, use topical applications, use mouthwashes, You can advise the patient to apply petroleum jelly over the affected area. Facial nerve paralysis can occur if the needle penetrates the parotid gland capsule, which is behind the mandible. So facial nerve paralysis occurs when you're giving inferior alveolar nerve block and you go too deep, too far posterior behind the mandible and administer local anesthesia, which can actually numb the facial nerve ipsilaterally on the same side. The anesthesia is transient and unilateral paralysis of the chin, lower lip, upper lip, cheek, and eye can occur. It is temporary. Counsel the patient, but there can be risks if the patient because the patient is unable to close the eye. So make sure you follow basic principles of atraumatic technique. Avoid over insertion of the needle. Let's say you're unable to find the lingula and you're going deeper. If the needle penetration depth crosses 2/3, come back. Withdraw the needle slightly and point the tip of your needle slightly anterior. Once the paralysis has occurred, reassure the patient of the transient nature of the paralysis. Advise the patient to use an eye patch until motor function returns. If contact lenses are worn, they should be removed. Record the details in the patient's chart. Superfluous anesthesia is unwanted anesthesia of other nerves. For example, ocular complications following temporary paralysis of cranial nerves 2, 3, 4, and 6 have been described. Proposed mechanism is that intravenous transport of local anesthesia to the cavernous sinus can occur in a retrograde fashion, and that can lead to oculomotor or abducens or trochlear nerve paralysis, which is also transient. Make sure you do careful aspirations. What happens is when you're giving a block and you introduce the anesthetic agent into the vessel, into the retrograde flow can occur through that vessel and enter the cavernous sinus where most of the nerves are present. Most of the nerves supplying the ocular structures are present. So the lesser palatine nerve is commonly anesthetized when performing a greater palatine injection. The patient will notice a transient loss of sensation on the affected side when swallowing. So lesser palatine nerve, which supplies the soft palate, can get anesthetized and swallowing will be compromised. Okay, like almost all complications, make sure you aspirate. Superfluous anesthesia most of the times is unavoidable. Reassure the patient that this is transient. If there is ocular involvement, monitor and manage symptomatically. Extremely rare complications of local anesthesia is infection because all of the needles that we use are sterile. If a patient is immunocompromised, infection can occur. The normal flora of the oral cavity are not a concern because they do not lead to infection in patients who are not significantly immunocompromised. If the patient is immunocompromised, make sure to prescribe a topical antiseptic like a chlorhexidine or a betadine mouthwash. Infection will present itself with pain, fever, trismus, one day after the injection. Infection always needs time to develop. When there is an active site of infection such as abscess, needles should not be inserted within the site. Not only would the low pH prevent onset of local anesthesia the action, but the infection could spread as well. So you can actually seed the pus into deeper tissues if there is an infection. How to prevent? Always use sterile disposable needles. Do not contaminate the needle by contacting non-sterile surfaces outside the mouth. In severely immunocompromised patients, consider a topical antiseptic prior to injection. Let's say there is an established infection. It needs to be treated like a normal infection is treated. Like prescribe antibiotics such as penicillin in an appropriate dose and duration. If there is an established abscess, we need to drain it as well if needed, and obviously record the details in the patient's chart and follow up to determine progress. That's it for today's presentation. Next time we are going to do types of local anesthesia according to their actions. For example, topical, block anesthesia, infiltration anesthesia. Thank you very much.